Okay, this lecture covers fungal infections and a few others. So the others we're going to start with is Lyme disease. So this is Borrelia burgdorferi. We do have this in Idaho occasionally. More commonly is Rocky Mountain spotted fever, and that's more in the Dakotas. This is a deer tick. And the Lyme disease has this kind of characteristic rash that's considered a bullseye rash. Patients have found a tick on them, generally in their hair. They like these dark areas, so either in your hair, sometimes in your armpits, in your growing area. Patients will have joint pain, they'll feel tired and have a fever and no energy. It is a gram-negative bacteria. The treatment is antibiotics, but if patients have waited too long, it's not effective, and it can be kind of tricky because the symptoms can actually occur 2 to 3 months out from having this tick. Psittacosis. Psitta is a Greek word from parrot, and these are an infectious disease in human that has mild, nonspecific flu-like symptoms, and these are from aerosolized bird droppings. So why do they come and be seen in respiratory care? Because the patients wind up wheezing and shortness of breath, and it can cause bacteria. When it's a bacteria transferred from bird to a human, again, it's that zoonide from their droppings. Mycobacteria, it's their own category. It's this kind of in part because they have a thick, waxy cell wall membrane. It's not a spore, but it does protect the organism. And there's over 70 species of mycobacteria. The two major ones are this Mycobacterium tuberculosis and Mycobacteria leprae that causes leprosy. We don't see much in the United States. In other countries it's more prevalent, where they get this kind of white colored skin that breaks down very easily. So those are the two major pathogens, the Mycobacterium tuberculosis and Mycobacteria leprae. The remaining of these mycobacteria are put into this category of MOTS, mycobacteria other than tuberculosis. These are opportunistic infections. So again, it waits for our immune system to be weak, where maybe a patient is neutropenic from cancer treatment, and others that have a weakened immune system, such as patients with AIDS. So if we look at Mycobacterium tuberculosis, this is where we would do that Ziehl-Neelsen stain, the acid-fast stain. It is an airborne transmission. They look like these kind of slender, straight, or slightly curved bacilli, non-motile, non-encapsulated, and they don't form spores. Their target area is the lung. Occasionally it affects the kidney, spine, or liver. So on to MOTS, this large group of Mycobacterium other than tuberculosis. These are generally an opportunistic infection. Person-to-person transfer does not take place, but they are transmitted. Generally resistant to drugs used in the treatment of tuberculosis, and combination agents have been found to be effective. The two we're going to focus on are the Mycobacterium avian intracellular complex, called MIA or MAC. These are more common, and so those are the ones I want you to focus on, are the MIA or MIC. On to fungal infection. So we've talked about this when we were talking about patients that use an inhaled steroid that don't rinse out their mouth. We get that development of thrush because we're depleting some of the normal organisms that are keeping our mouth clean, or keeping our mouth full of organisms that we want there, and we provide an opportunity if people don't rinse that off. So here's a list of some of the ones we're going to cover. So Pseudomonas pneumonia, or PCP, is sort of the old name, or pneumocystis. Oh, sorry. Pneumocystis is the older name. Pneumocystis pneumonia is what we're going to call this more often. Who gets this infection? It's primarily HIV patients that already have cancer or other immune compromise. Without treatment, people over 85% of HIV patients will develop PCP. The important thing to remember here is it's caused by a fungus. Used to be called Pneumocystis carinii, but now it's referred to as Pneumocystis eurovinci. So histoplasmosis. This will cause a pneumonia. Where is this found? It's found in the soil. It's microscopic fungus found throughout the world in river valleys and soil where bird or bat droppings resume. It's released into the air when either the fields are plowed or people are sweeping out chicken coops or digging holes. Histoplasmosis usually affects the lung and causes short-term treatable lung infection. The problem is it can disseminate or move, and that's where it becomes a little bit more of a problem. So we breathe it in. Most of us, again, our immune system is going to take care of, but others it may not. And then it may transfer from breathing in to transferring to the joints, and that's where it can be a little bit trickier to treat. Again, this is a fungus, so we would treat it with an antifungal medication. Coccidioidal mycosis. Coccidioidomycosis. This is a fungal infection, otherwise known as valley fever or San Joaquin Valley fever. It tends to reside in California and Arizona. It's an infectious fungal lung disease acquired by inhalation of arthrospores that become airborne from fungal pieces in the soil, these organisms in the soil. Approximately 60% of the primary infections are completely asymptomatic. So they'll have a cough or cold and they'll breathe in, and most patients recover fully. The majority of the 40% recover completely from this flu-like illness, consisting of cough, fever, and pleuritic chest pain. However, it may scatter. This tends to affect patients that we refer to as snowbirds, those that may live in Idaho in the summer, and as soon as it snows they fly away to places like Arizona, and the elderly tend to be exposed to this and it causes a problem. Blastomycosis, this is a fungal pneumonia, again found in the soil. It's a symptomatic infection in about half of the cases. The patient generally thinks they have kind of a cold or flu. Sounds really similar to these other ones. Most get better on their own. But again, the biggest thing here is to identify that it's a fungal infection. Aspergillosis is more common in Idaho because many of these other funguses, we don't have a lot of fungus in Idaho, in part because we have such a dry climate. Aspergillosis, though, can be caused from mold in the home, and it tends to have, again, be in immunocompromised patients. and this is breathed in. One precaution here is if there's a lot of dust that you're working with, to wear a mask, and it helps protect you somewhat. Cryptococcus. Crypto, you think of dead bodies. These are dead particles, again in dust and air. Rare in patients with a healthy immune system. This Cryptococcus tends to have kind of a delay in diagnosis. The way we determine that somebody has this is through bronchoalveolar lavage. Again, this is something found in bird droppings, and the majority of the cases tend to be in those with HIV. Okay, candidias. This is one we see occasionally. This is what we refer to as thrush. What they find is they have this oropharyngeal infection, sometimes called an OPC, oropharyngeal cavity infection. White mucus patches caused from this Candida albicans, part of the normal microflora of the mouth or gastrointestinal tract. Fourth most common cause of nosocomial bloodstream infections, and again this is so pretty common. Remember, fungal. Children can get this also from having milk left in the mouth. It's really painful. We have it in our mouth right now, but we're okay. If you were to think of somebody that uses excessive mouthwash, if you use mouthwash 3 or 4 times a day and we're always clearing out the normal flora, you're going to provide an imbalance of the microbial balance within your mouth, and you could potentially cause yourself to have a yeast infection. All white patches, however, are not yeast. Just because you look in somebody's mouth and you see some white patches doesn't mean they have candidias. But there are some antifungals that will treat this, so they'll do an oral rinse of nystatin, and patients always remember this. It tastes fairly bad. They don't like it. So how do we diagnose fungal infections? Don't you love this little picture here? Again, stressing, categorizing all these things to be a fungus. A lot of times it's signs and symptoms, really similar to other things that we've talked about: cough, fever, crackles, sputum, shortness of breath. We'll do some skin testing, some anti-antigen body reaction. There can be some serologic testing, a blood titer for rubella or rubeola, occasional bronchial alveolar lavage and cultures, and get a chest x-ray. So treatment for these. There's a few anti-infungals that we have. Nystatin is the drug of choice for candidias again. Nystatin is this thing where we'll swish and swallow. Patients always remember this. The medicine must taste horrible because they remember this, trying to get rid of this infection. Itraconazole is what is used to treat athlete's foot, or Tinactin, maybe something you see over the counter to treat kind of jock itch, is that topical treatment. It can be given IV for blood fungal infections. Amphotericin B is an older medication, but it still works good, and so that is also used. Another place fungal infections will grow in hospitalized patients that are similar to athlete's foot and jock itch is in obese patients. They have those moist folds. And if left untreated, that skin can break down from that fungal infection within the skin folds and get into the bloodstream.